Bartonella species. In the US, around 20,000 cases of Bartonellosis were reported annually. Next. Okay, this is a result. This is a preliminary result of a retrospective study on a seropositive IgM and IgG towards Bartonella henselae among suspected patients in Malaysia. And it is shown that the seropositivity rate of IgM among these patients are 42% and IgG is 71%. So this value, this seropositivity rate that is shown in this study is way higher than the previous study by T et al. In 2021. Next. And the percentage of seropositive cases showed an increasing trend from 2015 to 2019. And the range of seropositivity per year for IgM is around 9 to 31%, and for IgG is 16 to 26%. Next. So multivariate analysis on factors associated with seropositivity of Bartonella henselae among suspected patients showed that the age group of below 50 years old were significantly associated with seropositive case. And the younger age group has high value of adjusted odds ratio. Meanwhile, for the clinical manifestation, inguinal and axillary lymph node as well as fever has a significant association with the seropositive case, with axillary lymph node has the highest adjusted odds ratio. Next. Okay, now let's look at how to investigate and confirm CST. So the laboratory tests for CST or cat scratch disease are comprised of two, which are the microbiological diagnosis and histological diagnosis. Microbiological diagnosis, next. Microbiological diagnosis comprise of direct detection of the pathogen and DNA, i.e. the isolation in culture, microscopic visualization, and PCR detection. And indirect detection involve the serology test against detection of antibodies against the pathogen. Next. So first, let's look at the culture test. Culture in Bartonellosis is very challenging as there is low level of bacteria persistent in the blood due to cyclical bacteria nature of Bartonella. It is also fastidious and slow growing that may take 1 to 4 weeks of incubation. And there is a need of humidified 5 to 10% CO2 environment. And there is a risk of growing environmental contaminants due to the prolonged incubation. Next. So there are a few studies that recommended special media for the isolation. And the list are Brainheart Infusion Agar, Columbia Agar, liquid media for insect cell growth, the BAPGM media, and Schneider's Drosophila medium. Identification can be made by multi-TOF and also Vitek2. Looking at the picture at the right-hand side, there are two types of culture morphology which give a different impression on the clinical cause of the disease. For the first one, is this irregular, raised, rough, dry, white cauliflower-like colonies, which normally being isolated in a prolonged incubation. And this is usually isolated in patients of chronic and persistent illness. Whereas in the second picture, there is a small circular tan and moist tending to pit at the agar. And this actually refers to the colony of culture that is able to be isolated within a shorter time, that is 5 to 15 days. And it signifies an active and acute infection. Next. And Bartonella can be visualized microscopically using silver stains in tissue histopathology examination at the necrotizing granuloma lesion. And the silver stains used are Wattin-Starry, Steiner, Dieterle stains. However, late in the course of Bartonella henselae infection, organism may not be found. Species-specific direct detection by immunohistochemistry stain can also be used. However, it is expensive, not well characterized, and not widely available. Next. Serology tests remain an important tool to diagnose Bartonella infection due to the fastidious nature. And the tests include indirect immunofluorescent assay, enzyme-linked immunoassay, and the Western blot. Western blot is normally used in the research, and sensitivity of serology tests can range from 50 to 80%, and specificity is 90 to 100%. Sensitivity may be influenced by the clinical index of suspicion, types of antigen used, and the seroprevalence in the population. In the IFA test that is currently available in a reference lab, the IgM generally rise on a primary infection and persists for 3 months duration. Hence, it is lacks of sensitivity. Next. So, to get a recent acute infection, to confirm that a recent acute infection, we need to get a rise of IgG titer in PET sample that is at least 2 to 3 weeks apart. Other than that, IgG titer from a sample of more than 1 in 512 titer in a single sample can confirm a recent acute infection. An early acute infection is suggestive when the titer is 1 in 64, which is considered a positive test. However, this may indicate past infection or past exposure, as a positive result may persist for years. Next. Challenges in interpretation in serology tests are the cross-reactivity that has been reported for Bartonella henselae is actually is common to have the cross-reactivity with other Bartonella species, for example, Bartonella quintana. And they are also reportedly to have cross-reactivity with other tick-borne diseases such as rickettsia, coxella, and orangea. And results of the serology may be negative in early disease course, and if they are positive, they may persist for years even after effective treatment. And there is also variation in the sensitivity, whereby the highest, it can be highest in sensitivity in immunocompetent patient, and it can be lowest in sensitivity at the late stage of AIDS patient. Next. So for PCR test, PCR and IMR for Bartonellosis detects DNA of Bartonella henselae and Bartonella quintana, and the specificity is around 100%. However, the sensitivity depends on the type of samples that are tested. So for tissue biopsy or aspirate or the fixed frozen paraffin embedded are generally higher in sensitivity. For example, in lymph nodes, the sensitivity is around 80 to 90%. Excised cardiac valve tissue is in infective endocarditis is very high in sensitivity, around 90 to 95%. And skin or subcutaneous lesion in bacillary angiomatosis cases is around 85 to 90%. Other samples accepted for PCR are also anterior chamber fluid in the neuroretinitis cases or the perennial oculoglandular syndrome and ETC can also be used for PCR, and the minimum volume needed is around 200 microliter. CSF sample can also be sent in cases suspected for cat scratch disease encephalitis. And blood, however, had the lowest sensitivity range around 33 to 58%. However, tests can be considered in an early course of the disease or patient who has not been started doxycycline or azithromycin. Next. The advantages of PCR test is that it, besides being a definitive, besides giving the definitive identification, it is also able to differentiate between Bartonella species using multiplex PCR as well as sequencing. The target genes that normally being used for Bartonella henselae are the serine peptidase, HTRA, the 16S srRNA, the citrate synthase, GLTA, and others. For Bartonella quintana, 16S rRNA is normally being used in PCR. Next. So Bartonella PCR test will be started in IMR from 20th November 2023. However, order is made by consultation, whereby physician can contact me and present their case, the medical case, the case findings, and later when the case is accepted for PCR test, they need to fill up the Bartonella PCR test available at SMI's website. And please write down the date and time that they have spoken to me. Next. Okay. The histology diagnosis of CSD is primarily based on the lymph nodes biopsy. Next. So histopathological examination of tissue CSD usually shows neutrophil infiltration and granulomatous changes, which are marked by the presence of epithelioid granulomatous inflammation with multinucleated giant cells and central necrosis. Biopsy of lymph nodes for histology or FFPE in combination with PCR test is a very competent diagnosis for CSD. Besides that, electron microscopy study on tissue can be used to demonstrate bacilli that is present between collagen fibers. This is normally being used in research. Next. So what are the tests that are available at the reference lab? First, PCR can be sent to IMR, and the sample that can be used for PCR are tissue, FFPE, skin, CSF blood, and the date of onset should be less than 10 days. Next. Then the serology test, which is IFA, can be sent to Hospital Sungai Buloh. And ideally, the sample should be taken around second week of illness, and it needs to be paired with another sample 2 to 3 weeks apart. Next. So criteria for CSD diagnosis, there is two diagnostic criteria that is available for CSD diagnosis. A classical diagnostic criteria, which is a combination 2 out of 3. The epidemiological criteria is described by the close contact with cats or scratch or bite from cat. Histological criteria denote the typical CSD histology, and the microbiological criteria is the presence of positive serology or PCR or culture test. Next. So Margilit et al. 2000 have come up with a new diagnostic criteria for CSD that is a combination of 3 out of 4 criteria. And in this criteria, epidemiological and histological remain the same as the classical one, except for the microbiological serology is a standalone criteria, and there is an extra criteria which is a combination of serology, culture, PCR, and also radiological findings. Next. So what do we learn from this case? let's look at the key insights. Next. So the story of Sabina continued. Sabina has sought medical treatment at the hospital and was admitted, and she completed 2 courses of antibiotics, Zinacef and Augmentin. However, symptoms still persist, and so does the lymph node. And the biopsy of lymph node done when she was taking the Zinacef at day 5, and results showed that there was micro abscesses associated with few aggregates of histiocyte, forming vague granuloma with central abscess formation. So, depending on this result, the physician has stopped the antibiotic and started on azithromycin 500 mg for 5 days, and symptoms started to improve. And upon further questioning, Sabina revealed that she was on azathioprine for severe eczema. FFPE of the lymph node biopsy was sent to IMR for TB PCR test to rule out TB. Next. And TB PCR result showed DNA was not detected. Next. However, Bartonella PCR was detected, that is specifically Bartonella henseli DNA. Next. So the mystery is solved. Sabina had cat scratch disease. Next. So challenges to diagnose CST is that CST is normally a diagnosis of exclusion, and they are normally not included in differential diagnosis. Thus, it is normally being undetected and undiagnosed. It is also fastidious organism. It is caused by a fastidious organism and not easy to isolate with current routine microbiology lab setting at the hospital. The illness may be presented with mild and unspecific symptoms, and thus it goes undiagnosed. So misdiagnosis is possible as co-infection is common, especially in occupational exposure. And currently, there is no surveillance system that is available for human and animal for CST. Next. So what is the way forward? Cases that is presented with fever, axillary or inguinal lymph node and has positive contact with cats should be ruled out for CST. A nucleic acid-based detection may result in conclusive serology result interpretation as well as cross-reaction. Laboratory-based surveillance may be used to track number of cases and pattern of disease, and later the result may be used to consider for inclusion of notifiable disease. And next is to improve awareness among healthcare workers and public by having awareness program to improve the knowledge, attitude, and practice. Next. Take-home message. Cat scratch disease is not uncommon in Malaysia. Any cat scratch disease suspected cases should be confirmed based on epidemiology, microbiology, and histology criteria. Consideration into notifiable infectious disease surveillance can initially be constructed from lab-based surveillance results. And more research is needed to understand the pathogen-host interaction and prevention strategies. Next. So with that, I thank you. If there is any further question, you can email me at this email address. Thank you.
Siti, are you do you have some time to take questions, or do you want the participants to send you the questions through email?
Actually, I should go for my meeting now.
All right. So any event or any question, if anyone has any further questions, please email your questions to Dr. Siti Roszilawati. So thank you very much for your presentation. It was very insightful in Bartonellosis. Thank you.
You.
So for our next speaker is Dr. Yazli Yuhana. One moment, yeah.
Hello. Hello. Can you hear me? Hello. 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 Hello.
I can hear you.
Okay. Hello. I'm. Am I online yet?
One moment, yeah.
All right.
Can you see the screen?
Yep.
Okay, go ahead. Let me give you a brief introduction. So our next speaker will be Dr. Muhammad Yazli Yuhana. He is currently an associate professor of internal medicine and infectious diseases at the Graduate School of Medicine, KPJ University College. So he is also a very prolific researcher on Bartonella. So his title today will be Bartonella, It's More Than a Scratch. So without further ado, Dr. Yazli, go ahead. Thank
Thanks.
you.
Thank you. I like the word prolific. You say prolific.
Prolific.
Prolific. Yeah, prolific. I guess we did a lot of study in rickettsia, and surprise, surprise, the original name, the first name of Bartonella hensale is Rickettsia Cetaphilidae. Okay, so that's the origin of the Bartonella. I like the word prolific because in the end we will learn that unlike other gram-negative infection, Bartonella has a very close predilection to your blood vessels. Okay, they like to go into your blood vessels and proliferate your angiopathy, and hence you has all the bacillary angioma that we have listened to what Siti mentioned briefly just now. Okay. So today we talk about Bartonella. It's more than a scratch. Not just you don't have to be scratched by cats. You just need to be in close contact for fleas from the cats to bite you. Okay, so even your patient mati kata never been scratched, the patient may end up with cat scratch disease. Okay, just not doesn't matter from cats alone lah. There's a lot of other zoonotic mammalian reservoir that can harbor Bartonella inside them. Okay, we will see a few cases after this. It's more than a scratch because most of the time when you see this kind of case, you will end up sending a lot of other things lah, blood culture, TB PCR. You think of TB more than Bartonella. So if you tak ada duit, you scratch your head. If you insurance company, you will scratch your head as well. Okay, you spend a lot of money. Not to mention you end up with multiple antibiotics first before you end up with the right doxycycline or azithromycin lah. So in the end of the day, it's more than a scratch, literally and figuratively speaking. Okay, next slide, please. You will see images, and those patients, individuals have consented for their names and images to be up for discussion and write up and scientific sharing lah. Okay, next. So I'd like to share a case. This patient was seen by us in late August this year. Although he's from Colombia, Asia, there's no Colombia agar from there. I don't know that there's Colombia agar that we should use to grow Bartonella. Okay? I think it's a joke, but anyway. He presented to Colombia, Asia with acute fever for 4 days in early July. Then the fever subsided, but the reason he went there was because there is a progressively enlarging left inguinal nodes. Okay, left inguinal lymph nodes. 25 years old, never had of issue before. Okay, the first time. The lymph node was biopsied over there, and then the report that we got was granulomatous inflammation with central necrosis. Okay. But after the biopsy, the lymph node never regressed, okay, despite he received a doxycycline of a week. Hence, he was referred to Ampang Putri for further workup lah. So at home, he has a lot of cats, but he never really main dengan kucing lah. So most of the time, the cats are the neighbors' cats, and he typically had history of being scratched or bitten or traumatized by the cats. Okay, he has no other pets at home. When we see this kind of cases, I tend to make sure that we're not dealing with any opportunistic infection or any funny infection. So he has no identifiable risk factor for immunocompromised, being retroviral disease infection or any progressive cancer, or he does not take any traditional medicine that may contain steroids. Okay, all in all, he seemed very immunocompetent from the history point of view. All right. So basically, when we saw him, he already about day 60 of illness lah. So preceding by acute day 4 days of fever, nothing else, and then 2 months history of progressively enlarging left inguinal lymph node with discharge. All right, next. That's not him, that's other patient. What I'm trying to say is every patient that we saw, we try to look in the eye carefully just to make sure that we don't miss anything. Okay, that's me using the head fundoscopy. Okay, but on examination, this guy will go into the lymph nodes. Apart from the left inguinal nodes, there were no other palpable or enlarged lymph adenopathy. There were no rash, no skin lesion. The lungs were clear. Try to look hard for any other telltale signs that this might be immunocompromised patient with opportunistic infections. Okay, nothing. Okay, the vital signs were normal. So infection-wise, his Q so far 0. Okay, very mild, very non-severe manifestation of infection. His height was at 165 and body weight at 80 kilo. Okay, so basically his ideal body weight was BMI was high, okay? So usually, typically, when we think that we might deal with extra pulmonary TB, say that what happened in my head, I think I want to rule out TB lymph nodes, okay? Most of the time, our patient are having low BMI, like if they're not having any immunocompromised state, okay? So most of the time, they're on the low BMI side that predispose them to the extra pulmonary TB infection, so this guy is not in the low BMI category kind of patient. Okay, next. So this is what we saw on the left inguinal node. Okay, basically just a single palpable tender lymph nodes. Okay, with a purulent discharge from the biopsy site. Okay, there were no other palpable lymph adenitis. Having thought of, although he doesn't have any high-risk sexual activity or multiple sexual partners, so lymphogranuloma venereum was part of our thoughts. Okay, there was no penile ulcer, there was no penile discharge. So I'm quite sure that upon examining him, we're not dealing with any sexual transmitted issues. So basically just inguinal lymph adenitis with purulent discharge. All right, next. In seemingly immunocompetent patient, okay, so clinically he's well. So we send for basic bloods, HIV antibody, TB antibody, Siti, thorax and pelvis, just because I just want to make sure that we don't miss any other isolated abscesses. Okay, if this was TB, just make sure that we're not dealing with any Gons complex, any primary source from lungs. Okay. I spoke to Dr. Siti, so all physicians that want to refer case to her, make sure you refer betul-betul. She's very garang lah. So I spoke to her, then we agreed to run the PCR for Bartonella from the HPE tissue that we took in Colombia. For some reason, I don't know why I didn't send the Bartonella serology to Sungai Buloh lah. Over here we routinely send our Bartonella serology to the States, to Mayo lab. Okay, for some reason I don't know why. I'll speak to my colleagues in Sungai Buloh after this. And I started him on azithromycin with the back of my head. Couldn't be TB because he's looking so well. Doesn't have obvious risk factor for RVD until we get the HIV result. So cat scratch disease in immunocompetent patient was part of the differential diagnosis. Hence, started him on azithromycin. Okay, next. HB came back as normal, white cell normal, platelet normal, procalcitonin was very low. Okay, I didn't do CRP or ESR. Renal profile and liver function was okay. Lung CT scan were unremarkable, nothing to suggest of possible TB there. And there's only one node that was enlarged with necrotic center detected by our CT scan. Okay, so as you can see, the head of the pan show basically 2 × 3 centimeter of left inguinal lymph node with necrotic center, nothing else. Next. So RVD came back as negative. TB gold interferon negative. PCR Bartonella was not detected. But that was his lymph nodes after 3 days of azithromycin. Okay? So basically, without touching the nodes, without aspirating the lymph nodes, the lesion regresses on its own, okay, with azithromycin on board, okay. Shall we send Bartonella PCR, blood Bartonella PCR? So Dr. Siti said, tak payah, okay, because yeah, understandably the sensitivity from blood is very poor in immunocompetent patient, okay. So we'll see another case that is different to this guy, okay, when you are immunocompromised, okay. Next. So that was his inguinal lymph nodes after day 7 of azithromycin, basically dry, very much smaller. In the end of the day, we got the serology for Bartonella Hensale from the Mayo laboratory. That was taken on day 60 of illness. Okay, you can see that the Bartonella Hensale IgG was rocketing high at 1 in 2048 titer. Okay. A cutoff of 1 in 500 was only needed in a single sample. Okay, so this is a surefire case of a cat scratch disease in immunocompetent patient, okay, with inguinal lymphadenitis. All right, so usually we don't think of cat scratch if the nose involvement is inguinal, so it's a bit odd, not to say a bit odd, although Dr. Siti punya statistical analysis so that either axillary or inguinal are associated with cat scratch, but in general, if you look up in literature, inguinal involvement is quite rare. Most of the time it's axillary, post-trochlea, okay? And suppurative some more, okay? Most of the time the lymph nodes are very dry and not non-secreting lah. So this guy has suppuration lymph nodes, which is quite a rare encounter in cat scratch disease per se, okay? But in the end, this is a case of cat scratch disease, all right? Next. So this is a recent case report from the States, okay, by Lancet last year. Unlike our patient, this guy is immunocompromised, okay? He has underlying HIV, 31 years old, with acute history of fever and bloating, okay? So his HIV was very well controlled. He's on antiretroviral treatment. The viral load was suppressed. The CD4 was more than 300 upon diagnosing, upon presentation to this hospital. The state hospital, not my hospital. He had renal transplantation for HIV-associated nephropathy. So he's on immunosuppressant, mycophenolate, prednisolone, okay, before he came to the hospital with 2 weeks of fever. Socially, he had a dog, okay, a dog, not cat, a dog with a poor health, as described in the case report. Examination-wise, unlike our patient, he's very unwell, tachycardic, fever, tender abdomen, and hepatomegaly. No identifying lymphadenopathies, no identifying skin rash, okay, just liver hepatomegaly, which is tender, okay, nice. Unlike our patient, he is pancytopenic, okay, 2 white cell of 2, hemoglobin of 8, platelet of 30, cholestatic jaundice with alkaline phosphatase of 180. They didn't do procalcitonin there, I don't know why, but they did CRP and ESR, which were elevated, okay. But if we did CRP in our patient, I don't think it will be elevated as well, because as much as possible, our patient has very localized infection of Bartonella, in which the lymphadenitis. This guy is totally not like our presentations lah. All right, nice. So they did biopsy the liver. They see a proliferation of vessels, okay, filled with blood, okay. Consistent with paleosis. Basically, paleosis is when you see angioproliferative reaction in either liver, bone, or spleen. Okay, that's when you use the word paleosis. Otherwise, if involves other organs, then you use the word bacillary angiomatosis rather than paleosis. Okay. And by the silver stain, the warty stains, okay, you can see that they managed to demonstrate the coccobacilli clumps in the blood vessels. Okay. Next. The serology came back as 1 in 500 for IgG, 1 in 16 for IgM for Bartonella henselae. The PCR that target the heat shock protein, okay, one of the target protein that Dr. Siti mentioned as well, was detected. So this is a confirmed case of Bartonella infection, which is causing, next, hemophagocytic lymphohistiocytosis reaction. Okay, next. I mean, HLH lah. Basically, the Lancet case study presented a patient who is immunocompromised in a sense of immunosuppressants drug from the kidney transplant, not from HIV, all right, who came with HLH, okay? So basically, unlike our patient, this guy was very ill, okay? He got vancomycin and pictazocin first when he presented to the hospital, until they find the HPE reports of the liver and the bone marrow, which are consistent with HLH, and confirmed by PCR and serological diagnosis of Bartonella henselae. Okay, with the I guess the clue was living with a pet dog. Okay, echo was normal, eye examination were normal. He was put on doxycycline and discharged. Unfortunately, in the case report next, he came back after that with persistent fever. The thing, it was a flare of the Bartonella hensale, the cat scratch disease, and he was put on doxycycline for a year. And they reported that 2 years after that, he was fine and doing well. So this was a case of disseminated Bartonella hensale infection, disseminated cat scratch disease, okay, which doesn't involve the lymph nodes at all, but it involves the liver, it involves the bone marrow, okay, in which a rare presentation in a sense, okay. We don't see that much among I guess we never see that much in our patients lah, but cat scratch disease can be as severe as this in immunocompromised patient, especially those patients that live with retroviral disease. Okay, next. So most of the time, our cat scratch disease are self-limiting. Okay, so basically they can just present with lymphadenitis, and that's all. Like what we saw in our patient. Okay, the keyword is self-limiting. I guess I do miss a few patients that I thought was sporotrichosis. Okay, because the lymph nodes was enlarging along the upper limb like sporotrichosis. They like sporotrichosis. They did have contact with cats. Okay, so cats is a common variable for both sporotrichosis, lymphadenitis, and also cat scratch disease, unfortunately. Okay, so we put the patient on itraconazole. Lesions are getting better. I thought I'm very happy. But when we sent the serology, it came up from 200 to 500 lah. So without any azithromycin or doxycycline on board. So in a sense, it is true that in immunocompetent patient, if you leave the patient alone, it's going to be self-resolving, because that's one of the reasons why culture is very difficult, because once you get Bartonella hensale, and even if you are immunocompetent, the immune reaction are going to be very robust. Okay, hence the very low yield of culture and PCR and whatnot. So serology become the backbone of diagnosis. Okay, not the other way around. Okay, in immunocompetent patient. Okay, so you need to have a contact with cat. So I guess if you are immunocompetent, a cat would be just enough for you to refer your case to Dr. Siti lah. But if you are immunocompromised with whatever, okay, I guess not just cat lah. We just learned from the United States case that unlike not living with cat, the patient was staying with a dog. Okay, so as long as you have a pet and you don't have any other diagnosis, okay, it could be a dog scratch disease lah, and doesn't have to be cat lah. So as long as you have a pet, and if you are immunocompromised, we need to think of Bartonella hensale infection at some point. Okay, most of them are going to be localized. Only a portion are going to be disseminated. Okay, next. So this is what we saw in literature. Okay, most of cases have the axillary involvement, the epitrochlear involvement. Okay, neck, cervical, 20% inguinal, and only 1 in 10 patients have suppuration. Okay, like the case of our patient. Next. Those without regional lymphadenitis, okay, they can present with hepatosplenic involvement, neurologic involvement, encephalopathy, radiculitis, ataxia, eyes problem. Okay, they can have uveitis, neuroretinitis, Perinots, like Perinots syndrome. Okay, where you have a lot of inflammation in the eyes. Okay, those are the rare extra glandular manifestation of cat scratch disease. Okay, brain, liver, spleen, eyes. Right. These are one of case report where a child presented with renal artery occlusion. So remember that the Bartonella hensale has very have tropism against tropism for angioproliferative. Okay, once you get into you may end up with arterial occlusion, for example, in this child. Okay, next. We learn about other manifestation from the second case. Okay, presented with hemophagocytosis, hemophagocytic lymphohistiocytosis. Okay, HLH. In Malaysia, we see a lot of secondary HLH due to dengue. Okay, but we do bear in mind that It can be a manifestation from other infection as well, commonly described in Epstein-Barr virus, but we do see more HLH presentation in other infection as well. Septic arthritis, osteomyelitis, and culture-negative endocarditis. Okay, in IgN we have a lot of we do see Bartonella endocarditis in those who presented with culture-negative endocarditis. Okay, next. And a bit on culture-negative endocarditis. So if this is a case of Bartonella infective endocarditis, okay, so I can still remember we have Bartonella quintana infective endocarditis in a patient in IgN who was a homeless, okay. So basically, the literature described that if you are dealing with Bartonella infective endocarditis, number one, your culture most of the time will be negative. And it is almost always associated with glomerulonephritis. Okay, so in a setting of a kidney failure patient with IE, okay, culture negative, exposure to cats, okay, so exposure to crowded areas. Okay, Bartonella quintana is associated with crowded areas where the human body loss is the vector. But if you have a cat or any animals, so you must think of Bartonella hensale. Okay, so those with IE is going to be associated with glomerulonephritis if this is a case of Bartonella infective endocarditis. Right. Next. So unlike other Bartonella species, only Bartonella hensale, okay, cause angiomatosis in your liver, spleen, and bone. Okay. This is what they call it paleosis. Okay, if the blood vessels proliferation happen in your liver, spleen, or bone, okay, we term it as paleosis. If the blood vessels proliferation happen in other organs, they call it angiomatosis. Okay, so bacillary angiomatosis or bacillary paleosis. All right, next. Bacillary angiomatosis can happen in any species, but bacillary paleosis only happen in Bartonella hensale. We will see why. So this is the thing about Bartonella. They like to proliferate inside the endothelial cells, and once they're inside the endothelial cell, they can induce more proliferation. Okay, unlike our mucormycosis, where they like to invade our vessels and rupture. This guy, the Bartonella, like to get into our blood vessels and proliferate. Okay, so it causes issues with that. Okay, so that's what's unique with Bartonella, and that happens only in immunocompromised. Okay, not immunocompetent. Immunocompetent, for some reason, we just end up with lymph nodes. Okay, but in immunocompromised, you're going to end up with this funny angioproliferation. Okay, that can happen in your liver, spleen, marrow, skin. Okay. And any other organs now that you can think of it. All right. Next. So why? Okay, why they like to cause this proliferation? Okay, this is an electron microscope of Bartonella hensale. So basically, the round is the Bartonella. The hairy picture around it is what they call the Bartonella adhesin A, or bad A, like a bad A. Okay, so this bad A is responsible for the proangiogenic response. Okay, so these bad A are the key factor for the virulence key factor, and also the reason why they trigger the proliferation of the vessels. Okay, so and this structure I don't think has been described in any other gram-negative organism like angioproliferative tropism. Okay, so that's what I think a good characteristic of what we should learn from Bartonella hensale. Okay, in which the proliferation is going to be very much seen in immunocompromised patient. Okay, but not in immunocompetent patient. Okay, so they can, but very small percentage of immunocompetent Bartonella hensale infection will end up with disseminated infection. Once it becomes disseminated, we will see a lot of angioproliferation. Okay, otherwise, if it's localized, we just see lymph adenopathy and not anything else. All right, next. Like Dr. Siti said, there are many species of Bartonella, but in my reading, there are only 3 species that can cause significant clinical infection: Quintana, hensale, and Bacilliformis. Okay, they are very intracellular and facultative, hence very difficult to grow. Okay, one of the reason difficult to grow mainly because of the low volume of low biomass in our blood system. Okay, once it get into our blood circulation, if you are immunocompetent. Okay, next. Most are associated with cats. Okay, and you don't have to be scratched or bitten by cats if the flea from the cats excrete on your skin. Okay, you can get the infection as well. Okay, so you don't have to be having a physical contact with the cat. As long as the fleas from the cat can jump and bite you, okay, you can get cat scratch disease in a sense. Okay, and not just cats. So the second case that was published in the Lancet, there was no cats in the epidemiological link to patient. Okay, but the patient was living with a dog. Okay, so hen Saleh in the cat, but they were describing Bartonella vinsonii, okay, Berkhoffii in dog as well. All right. Next. So diagnosis, we need a strong epidemiological link. Okay, if the patient really say that I am anti-cat, I am anti-animals, then you can be safe to say that it's very much unlikely to be the zoonotic infection lah. But if there is any cats or any animals in the surroundings, okay, and patient come with, if this is immunocompetent, patient come with regional lymphadenopathy, okay, you should think of cat scratch disease, okay. But if this is immunocompromised patient, you can have more than that, okay. They're very ill, okay, HLH, okay, liver, osteomyelitis, eye issues, endocarditis, okay, you can name it. They can have those kind of manifestation, okay. The IgG is going to be very most sensitive in a sense, okay. It raise higher, faster than your IgM for some reason, okay. So if you send for the serology, look for the IgG of the hen Saleh, okay. Like in our case, it goes up to more than four raised from the 500 level, okay. HPE will show necrosis, granulomatous tissue, okay. Unless you ask for the silver stain, okay, then you might catch your gram-negative bacilli in the tissue lah. Okay, so from HPE per se and without a special staining, you may not be able to see the Bartonella, gram-negative Bartonella. Okay, culture are crab. Okay, crab as in tedious. Only 20%. Okay, are immunocompetent. Okay, but this literature describe if this is immunocompromised patient. Okay, your sensitivity from blood culture is much higher, okay, but in immunocompetent is very insensitive, okay. And PCR depends on our patient. PCR was negative, but he was receiving doxycycline back at that time, so possibly that's the reason PCR not detecting the organism. But it really depends on whether you have enough samples, okay, enough tissue samples, and the day of illness and everything. So PCR should be sensitive if we are using the right target genes and okay. So, but a negative PCR doesn't mean it's not, okay. So it depends on many factors as well, right? Next. So this just show that culture are not as good to diagnose Bartonella infection. But in literature, if you're dealing with immunocompromised patient and you think that this patient is having disseminated Bartonella and Saleh bacteremia, okay, so you should pick up your phone and let your microbiologist know that you might think of Bartonella and Saleh infection. You might prolong the incubation period, okay, up to 4 weeks, okay, or more, in immunocompromised patient. Okay, I'm not talking about immunocompetent patient. All right, next. So treatment, basically the literature describes azithromycin, okay, and if you can't use azithro for whatever reason, okay, then you can use clarithrobactrim or cipro or rifampicin lah. Maybe in Malaysia we use rifampicin the last, okay, but azithro should be number one. Claritro, cipro, bactrim, right? Next. And there's one look, previous slide back. Sorry. There's not much of RCTs in cat scratch disease. Okay, so there's only one paper that shows comparing azithro to placebo lah. So faster resolution, obviously. But they did not, we don't have until now any randomized control trial that compare azithromycin versus doxycycline, for example, okay? But in our case, you can see that patient did not respond for some reason to doxycycline, okay? But that happened in that hospital. I don't know exactly what happened, okay? But when we give azithromycin, you can see that within 3 days, 72 hours, the swelling of the lymph node regress, and we can see the clinical improvement, okay? So echo, which echo this 1998 RCT that compare azithro to placebo. Right, next. If you're dealing with disseminated infection, okay, azithro plus other, in this case they like to use rifampicin, okay, for disseminated infection, okay. If you're dealing with neuro involvement, okay, you may add on steroids as well. Nice. Like we said, so in neurological or ocular Bartonella Hansale infection, okay, the IDSA like to use rifampicin plus doxycycline, okay, for up to 6 weeks. Next. A bit of stewardship, okay. We know that in the end of the day, if this patient is immunocompetent, okay, they're having lymphadenitis, it will be self-limiting, i.e. you don't treat, the lymph nodes will get better, okay. So, but there is a small chance that in immunocompetent patient, the disease may be disseminated outside elsewhere, right? So that's why in adults, we do advocate to treat adults, although they are immunocompetent, with cat scratch disease, okay. But in children, most of the time they're going to resolve spontaneously, so you might not want to expose the kids to azithromycin, okay. But you need to discuss carefully with regards to why you should or should not treat the kids. All right, next. All right, that should be the end of my slides. Thank you.
Thank you very much, Dr. Yazli, for the very informative presentation. For right now, can we take some questions? Is there those with questions? You can please key in your questions either in the chat box or in the Q&A section.
No question? Any question?
Do we have questions?
You are in the UM, Kang Long, eh?
Yeah.
Right. What are you doing actually?
I work on a lot of tick-borne diseases, rickettsia, orientia, Bartonella as well.
Right.
We look more on the animal side lah. More on the animal side, yeah. So we are looking for yeah.
All right.
There's a question from Diana. So how do we treat CSD with any gram-negative covering antibiotics?
How do we treat cat scratch disease with?
How do we treat cat scratch disease with any gram-negative covering antibiotics?
Gram-negative covering antibiotics.
Question. Do we treat cat scratch disease with any gram-negative covering antibiotics?
I guess the question is, we're not sure whether you're dealing with whether your lymph. I presume you are talking about lymphadenitis, lah. So Diana asked whether we should use broad spectrum antibiotics that cover your beta-lactam antibiotics that cover your gram-negative if you're dealing with cat scratch disease. I guess the question here we should think of, if you think this is just a simple lymph node infection that's suppurative, okay, we should think more of gram-positive Staph aureus, okay, rather than your gram-negative, lah. All right. So if this is suppurative skin lesion, okay. So rather than gram-negative, you should think about covering Staph aureus in a sense rather than gram-negative. But for some reason, I mean, this question is, I guess, in a setting where you don't know the diagnosis. if you surefire think that this is a cat scratch disease, immunocompetent, they are well, they're not systemically unwell, okay? What I'm saying is they don't have fever, they're not lethargic, they're quite well, walking around, just a bunch of lymph nodes enlarged, they have zoonotic contacts, cats, okay? I guess we don't have to be worried about beta-lactam, broad spectrum antibiotic. Just focus on your cat scratch, okay? The keyword is very well patient, okay? Unless they are sick patient, okay, in which presentation is not like our second case, okay? So of course you will need to think of polymicrobial issues. So yes, gram-negative, gram-positive cover is up to you upon seeing the patient. There's nothing wrong there, but I guess rather than dwelling on whether patient respond on your treatment or no, you should chase after the diagnosis, okay? Make sure that you send the serology, make sure you send PCR from any tissue that you might think might pick up Bartonella infection, and stop the antibiotics if you have the diagnosis, okay? Because the antibiotics are so different, okay? I guess that's how we should take manage patient with this kind of possible issues.
Okay, so there's another question. One moment, yeah.
This question?
There is a hand raised.
Okay. Hand with lymph nodes or hand without lymph nodes?
I can't see the lymph nodes. Go ahead if you have questions. Okay, let's see. Okay, there's a anonymous attendee. What is the prevalence of cat scratch disease and how common is it? And what is the best sample with the highest rate of PCR detection?
I try to recall what Siti slide show lah. But I guess in the end of the day, di mana ada kucing, di situ ada cat scratch lah. I guess we cannot say our kucing don't have Bartonella inside. Doesn't make sense, okay? So I guess as long as the vectors, as long as the mammalian reservoir are there, cats, so Bartonella hensale should be there, okay? It's just a matter of who is around the cats. Because if you are immunocompetent, okay, so most of the time you might not come to the hospital with just a simple lymph nodes. And most of the time, if you see a doctor, the doctor might think of other things, okay? But at the end of the day, until you send the PCR or whatnot, your lymph nodes regress on its own, because in the end of the day, in immunocompetent cat scratch disease is a self-limiting illness, okay? Even without treatment, they're not going to be unwell. But if you are at the wrong time, at the wrong place, you are immunocompromised with cats around you, okay, you might end up with a disseminated form in which everybody will be jumping on the diagnosis. So I guess the prevalence should be, I guess, pretty much underrated, okay, because we did not look for it, doesn't mean it's not there, okay? And to answer the second part of the question, which have the highest tissue sensitivity, highest sensitivity for PCR, is it?
Yeah, that's right.
So I guess Siti's slide mentioned that the tissue, okay, should have the highest sensitivity. Makes sense, because if you learn just now, the hand sale is very angioproliferative. Okay, they like to be in the tissue. They have tropism to the endothelial cells, okay? So they proliferate inside there, okay? So it makes sense that the tissue that pick up the disease would contain the Bartonella hensale more, okay? So you have spleen, your spleen. You have liver, you have marrow, compared to your bloods, okay? If you're very immunocompromised, okay, your bloods should be having some promise to show positivity as well. Okay, tissue followed by bloods. I guess that's what Siti tried to show in the slide. Okay, but I like to mention that in disseminated disease, HIV is different from your cancer patient in Bartonella infection. Okay, so if they describe a very good case series. Okay, if you are immunocompromised from cancer or from hematological or from immunosuppression, you're not going to behave like HIV patient. Okay, so HIV, they have paliosis, okay, the bone, spleen, and the liver. Okay, but in the other group of immunocompromised non-HIV, they behave like your immunocompetent. Okay, so biopsy just show granular matters, necrotic tissues rather than proliferation of blood vessels. Okay, this is, I guess, this is what we are looking into, what people around the world are describing when we talk about Bartonella in immunocompromised patient. Okay, so two group of different patient with two group of manifestation: paliosis and HIV, the rest in immunocompromised non-HIV.
Okay. The next question is from Dr. Intan. She is a vet and consistently gets exposed to animals, especially cats. So what is the rapid diagnosis for cat scratch disease, especially after she has gotten the scratch? So just a mindful reminder to vets so that they don't overlook this matter.
You mean diagnosis to cats or diagnosis on the vets?
I think she meant to the vets. Good.
The vets,
Yeah.
not the cats. I guess the vet should look after the cats rather than yourself. That's a joke. I guess, Intan, if you are immunocompetent, I guess you should not be worried lah. So I don't think a constant exposure. I think like, well, we never know how constant exposure behave in people who've been constantly exposed to Bartonella infection. That's one thing, one angle that we need to look at. Okay, because it makes sense that the more exposure you have to the hand sale, the robust your immunity should be. Okay, the less ill you should be. But what we might be wrong. Okay, there might be autoimmune enhancement like we see in scrub typhus infection. The more you expose to Oryza tsugamushi, the more ill you could be. Okay. But in cat scratch disease, I guess we still don't know what's the risk of constant exposure to the infection. But as long as you are immunocompetent, I don't think you should be takut lah. But if you do have, okay, you should have limb adenopathy rather than anything else. Then I don't think we should prick your lymph nodes and send for PCR. I don't think it's quite necessary. Okay, serology will be the best diagnostic method lah. So take your blood, and I guess among the vet you should have your baseline serology for Bartonella hensale because you exposed to it. Okay, so you know your baseline serology is 1 in 200. That's it. But if you fall ill, okay, your serology should be higher than your baseline. I guess that should be a take-home message for vets lah.
Okay. So the next question, can the swollen appear at the calf site?
Calf site. Whereas I guess if you're talking about osteomyelitis with some funny tissue involvement, soft tissue involvement, it can. In the end of the day, lymph nodes are the primary organ involvement in immunocompetent. But if you have dissemination, okay, it can disseminate in your organs, bone. But I never heard of soft tissue or muscles involvement. Like, doesn't make sense because your blood vessels are not contained in those organs. Okay? If you have osteomyelitis, perhaps with some adjacent soft tissue, probably you can have a calf abnormalities lah. But I don't think would be a common manifestation of cat scratch lah.
All right. So the next question is from Diana again. She says, "Thank you, Dr. Yazli."
The vet,
No, Diana.
Diana,
The earlier attendee. So she says, "Thank you, Dr. Yazli." Another question is regarding pregnant lady who is infected with CSD. So is Bartonella teratogenic? And if it's spread to the baby, how long should we treat the baby and the mother?
Wow, that's a good question. No, I don't think it's teratogenic. I don't think because we don't know. ID would know the most important thing in that disease. Okay, we might not know that Bartonella is proliferatic angioproliferatic. We might not know the HIV thingy. Okay, but if this is something of importance, we should know. Okay, I don't think it's teratogenic per se. Okay, and I don't think means never come across any case description literature describing the issues of Bartonella infection in pregnancy. Okay, unlike your Zika, for example, where we know that it can cause microcephaly and whatnot. So I don't think it's teratogenic in a sense. So how to treat? Rather than doxy, you give azithromycin. Okay, if you're dealing with pregnant mothers with Bartonella infection. Does that answer the question?
Yeah. Right. That answers the question. Any more questions?
Shah, call me up. Anything, Shah? Can't pick up your phone if Shah is on the webinar.
If there are no more questions, can we conclude this webinar today?
Yeah.
Okay, thank you very much to our two very prolific speakers, Dr. Siti Rose and also Dr. Yazli, for this topic today on Bartonellosis. Very informative. And with this, let's conclude today's session. Thank you very much to all the attendees and also to the speakers.
Thank you.
For those who wants to get your CPD points, I'm going to paste the link onto the chat.
Wait, kau sakit kacau? Ah.
So I've pasted the link for you to register and also to get your CPD points at the
Slide
chat
apa?
box.
Tak dengar, Shah. Slide apa? Ah.
Thank you very much, everyone.